Hello and good day to you. This is Tracy Harrison from the School of Applied Functional Medicine, and I'm excited today to dive into the topic of food sensitivities. Food is such a powerful component of every clinical plan through the functional medicine lens. Regardless of what type of chronic disease dynamic you're seeking to prevent or to resolve, food is essential to consider, both in terms of its positive macronutrient, micronutrient support, but also potentially in the ways in which food can be negative. We're well familiar with highly processed, refined foods that can be toxin and chemical rich, but micronutrition poor. But many practitioners don't appropriately consider how foods may be part of the actual interconnected chain of causality in chronic disease. And today I'm going to share with you 10 common myths about food sensitivities, hopefully busting the myths and revealing some key truths and clinical pearls that you can use right away around navigating food sensitivities. So please stay with me for all 10 of them. And if this topic resonates with you, please share it with your colleagues. First of all, for those of you who may be unfamiliar, food sensitivities are a type of immune system hypersensitivity to potentially everyday foods we consume. Traditionally, conventionally, we tend to only honor food allergies, which are IgE mediated hypersensitivities to foods. And we're all familiar with allergies. These typically produce histamine driven responses that can be anything from mildly debilitating to life threatening. And allergies certainly may be part of the cluster of imbalances at play in unique patient cases. Especially with regard to the presence of high histamine load, which can cause all sorts of dysfunction. But food sensitivities, as I'm referring to it today, refers to type 3 hypersensitivities. And food, of course, is a ubiquitous part of our environment. And ideally, foods are something that our human immune systems well tolerate. But via a number of pathways, several of which I'm going to explore today, there are reasons why our immune system can lose tolerance to foods, including everyday foods we consume that are unknowingly promoting inflammation, perhaps even hypersensitivity to very healthy foods. So let's dive right in because IgE antibody mediated reactions to foods are not the only ones of clinical significance. And we need to be open to exploring the role that immune reactivity to foods is playing in chronic inflammation in our patients. The challenge is that food sensitivities have become a very hot topic. Many of your patients and clients may seek testing on their own in order to understand what are their sensitivities. And this brings us to our first myth that if you honor the concept of food sensitivity, you just need to do a test and it will tell you what foods are okay to consume and what foods are disease promoting. And of course, we only wish it were that simple. But the reality is that there are multiple pathways via which our immune systems can react to foods. At present, there is no single lab test that measures all of them. Most of them assess at most one or two of them. There are some lab companies that will pull together a combination package of multiple panels for you. But I think it's important to accept clinically that there is no test, no quantitative assessment methodology that's going to give you pat answers on what foods are okay to consume and which ones aren't. So let's dive into some of the detail here. When we're speaking of immune hypersensitivities, type 3, we are largely referring to both IgG and IgA, antibody-mediated responses to foods. IgG being the most prevalent antibody systemically, especially in the blood, and IgA being the antibody that is most prevalent in our mucosal interfaces. So, especially relevant for today's session in regard to the intestinal lining, which is where we ideally produce quite a bit of IgA for good, appropriate immune surveillance and protecting these mucosal interfaces or doorways, easy doorways into the body. And you can indeed acquire tests looking at IgG responses to a huge variety of foods. Different panels test for 10, 40, 60, 80, 120 foods. And less commonly, but importantly, you can also seek IgA antibody tests, which help you to understand in particular what is happening in these mucosal membranes, especially in the gut. But we also know that the body can have a non antibody mediated response to foods, which would not be measurable in any of these antibody tests. A person can also have an intolerance of a food, perhaps because of an inability to well digest the food. So, if we think about more generally negative responses to foods, or foods that are not supporting health for a unique individual, we have to consider food intolerances as well. We're all familiar with lactose intolerance, which is much more prevalent in our patient communities than we often believe, depending on the resource you consult. 2/3 to 3/4 or more of the world's adult population actually has lactose intolerance, but many of those people still try to consume dairy foods as long as they don't promote diarrhea. But we can have other food intolerances as well, perhaps fructose intolerance. Individuals can have histamine intolerance because, again, they are not optimally producing the enzymes that are needed to degrade some of these food substances. But we could even take that to a higher level. Some individuals are especially sensitive to higher levels of lectins in foods that are perhaps promoting various states of arthritis or joint pain. Other individuals may be intolerant or struggle with an overload of oxalates in foods that might be promoting recurring kidney stones or pain dynamics like vulvodynia. Or we could take it further. They may not well tolerate FODMAPs in plant foods. They may not well tolerate goitrogens or phytates. There are plenty of substances that naturally show up in normal, everyday, even very healthy foods that people may have poor tolerance of, or foods that may be pro-inflammatory. And so we need to stop looking for any lab panel to give us all of the good to consume or disease promoting to consume answers. We need to be looking at the full presentation of a patient that goes beyond food testing, antibody testing. And often people know what foods are causing problems. They may need support in eliminating that food so that their health can improve and they can experience a reduction in inflammation or a reduction in an overload of a food byproduct like histamine. Sometimes people know they need to eliminate it even, and they're just in resistance to it. And this is where education, inspiration, and empowerment is critical. But it's essential that you teach your patients up front before they collect their sample for any food test that no food antibody panel is 100% conclusive. If a food shows no, for example, IgG antibodies, that doesn't mean that they're not having high levels of IgA antibodies. Or sometimes people have a known allergy to a food and they would show high IgG antibodies, but they're not necessarily going to produce IgG or IgA. And Foods that are not well tolerated because of poor enzyme levels, those aren't going to show up on any antibody panel. You want to flag this truth to your patients and clients before they do testing so that they learn to look for the positives in any food test, but know that all the foods that show up as non-antibody activating may still be of concern for them or suboptimal as dietary choices for other reasons. So, food sensitivity testing can be very powerful, but no single lab panel is a black and white, good and bad type of assessment. We need to be more shrewd and looking for what is fueling a person's health or promoting further disease. Now, let's talk for a moment in particular about IgG, antibody-mediated responses to foods, because these are the types of food sensitivity panels that your patients and clients are most likely to have sought out on their own. Seems like every time I log in to a health-related website or onto a progressive health-related social media site, I see an ad pop up for a food sensitivity test. These are usually total IgG antibody tests that's simply looking at the full spectrum of IgG1, IgG2, IgG3, IgG4 that are being produced in a person's body in response to a food. And unfortunately, despite a lot of marketing otherwise, the reality is that all positive IgG levels are not necessarily a reflection of inflammation. Many of your patients have purchased kits assuming that if a food flags with moderate or high levels of antibodies, that food is a problem and needs to be eliminated. But IgG antibodies in particular are also a reflection of immune memory and the progression of the development of immune tolerance. This also means that younger children are more likely to have higher levels of IgG antibodies as their immune system is being primed and appropriately developing tolerance. In fact, if an individual has IgE-mediated allergies and they are undergoing some type of immunotherapy to develop greater tolerance, it is often the case that their IgG antibody levels will go up as their allergy is being lessened. Again, this is a sign of immune priming toward tolerance. And what this means is that total IgG testing is especially vulnerable to false positives. And this can lead to individuals being challenged or overwhelmed with the impetus to eliminate more foods than is really necessary. Some high total IgG findings lack clinical relevance. And generally, we don't recommend at the School of Applied Functional Medicine total IgG testing unless it is the only thing that is available. Instead, we recommend IgG testing that is also simultaneously assessing complement as a marker of actual inflammation in response to immune complexes. By measuring both total IgG levels as well as complement, we can help to weed out the higher IgG levels that are simply a reflection of immune priming and memory. And we can focus more specifically on the smaller subset of foods that are actually promoting inflammation via the complement pathway. This is, for example, lab testing like KBMO, where you are more likely to get a smaller set of positive food sensitivities that is much more reliable. Keeping in mind, though, that we're still only testing for IgG levels, which means some of the foods that don't flag high are not necessarily safe. Again, the immune system could be reacting or the body could be poorly tolerating via a different pathway. But a total IgG along with complement is quite reliable in terms of positive findings. And IgG testing, I think it can be quite powerful, especially it helps us to flag where the body might or the immune system might be more hypervigilant or dysregulated. Individuals can, because of other imbalances in the body, have lower levels of T regulatory cells, which help to calm immune reactivity. This can be as a result of anything from inadequate core nutrients like zinc and vitamin A to chronic infectious challenges, high viral load, yeast fungal overgrowths, parasitic overgrowths, bacterial overgrowths. A perpetually challenged immune system tends to become hypervigilant. We can have a loss of tolerance because of toxic overload. That's a known one of many mechanisms of how chronic toxic overload can dysregulate various foundational functions in the body. We can struggle with loss of barrier function, especially in the gut. This is often popularly referred to as leaky gut, but really enhanced intestinal permeability is a reflection of the loss of tight junctions between the microvilli in the body that allows overexposure of the immune system to what is happening in the gut. And this can be because of toxicity in the gut, microbial imbalance or dysbiosis, overgrowths in the gut. It can be because of immune hypersensitivity to gluten, and in particular to gliadin. That is a component of gluten that can cause us to produce excessive amounts of zonulin in the lining of the intestines that promotes greater permeability or loss of those tight junctions. Normally we have tight junctions that help to regulate permeability with minimal absorptive capability. But when we lose those tight junctions, then in addition to inflammatory mediators being able to leave the gut and trigger greater immune response, it's also true that partially digested foods can gain access to higher immune oversight in the basement membrane of our intestines and cause this reaction. If individuals already have maldigestion in the gut, that's going to make this dynamic even worse. But suffice it to say that we can develop via the gut IgG mediated food sensitivities, and we'll need to do an upstream investigation in order to understand the case specific drivers of that. I am a big fan of doing gut permeability testing, and the most useful and targeted type of mucosal barrier function testing is looking at antibodies to substances that we would really like to be retaining within the gut. There are a number of different companies that offer these, but we can look at antibodies to things like the protein zonulin or occludin, which is a protein that helps to maintain those tight junctions, or even lipopolysaccharide, a common endotoxin from gram-negative bacteria that is prevalent in the intestines. But if we are showing higher antibody levels to these 3 innate substances, it is necessarily an indication of this loss of barrier function in the intestines. And so understanding whether or not this loss of gut barrier function is involved in food sensitivities is really key. Because if you don't address the pathway, the reason, the mechanisms why an individual developed a food sensitivity, then they are very likely to just keep developing more and more sensitivities. This is what happens when people discover they have 4 or 5 potent sensitivities. In pursuit of reducing inflammation and improving their symptoms, they eliminate these foods. but then they find themselves feeling better for a time, but then eventually having either a recurrence of symptoms or the onset of new symptoms. And this is because if we don't address the pathway, the mechanism via which food sensitivities developed, then people are likely to develop hypersensitivity to the new set of foods they're consuming. And loss of barrier function in the gut is a common contributor to food sensitivities. So we need to assess it and resolve it coincident with food eliminations so that we are addressing the root causes. Now, myth number two, myth number two that I've been speaking about is the notion that IgG, antibody-mediated responses, are always a problem. And in fact, sometimes they are just a marker of immune priming and memory. So we need to be more nuanced in the testing we choose. Myth number three that I want to speak about is the distinction between IgA and IgG. And as I said earlier, one type of testing does not replace the need for the other. IgG testing is definitely most common in terms of foods that might be promoting systemic inflammation. If your patients, however, have known significant gut imbalances, perhaps chronic dysbiosis or mucosal degradation in the lining of the intestines, or bile acid malabsorption, or chronic diarrhea and known IBS. Any of these types of chronic gut imbalances can promote mucosal degradation and more immune reactivity in the mucosa. And this is where IgA testing, perhaps in addition to IgG testing, is highly recommended. We make IgA not just in the intestinal lining, but also in the mouth, in the lungs. And IgA responses may precede the more systemic IgG reactions. And so we want to consider where we want to be assessing IgA sensitivities in particular. Definitely an essential consideration when there is known enhanced intestinal permeability, especially where immune hypervigilance has proceeded to the development of autoimmune disease. So IgA and IgG are not interchangeable. They are distinct and need to be considered separately with regard to what types of hypersensitivities are most likely to be at play in a unique person. Myth number 4, you can't have food sensitivities if you don't have any GI symptoms, right? Well, that is also not true. Immune-mediated food reactivity can manifest far beyond the gut. In many cases, individuals have no GI symptoms, but they might have chronic postnasal drip. They might have headache. They might have frequent rashes. They might have joint pain. They might have postprandial fatigue. They might have mood imbalance, postprandial mood imbalances. These are all potentially reflections of inflammation from immune hyperreactivity to foods. So we want to look beyond the gut and gut symptoms and consider, again, where loss of barrier function, especially when combined with maldigestion, might be driving a hypersensitivity. Individuals can also potentially be born with hypersensitivities as well. Certainly joint pain or arthritis-like symptoms are a common manifestation of food sensitivities. And so we don't know for sure whether or not foods are a problem until we eliminate them and then do a structured reintroduction. In fact, the gold standard of food hypersensitivity identification, even in conventional immunology, is structured elimination and reintroduction. Now, when an individual has elevated antibodies, say high IgG antibodies to a food. We teach practitioners to guide their patients in embarking on a 4-month elimination of that food, not a reduction, but an elimination. And there is a reason for the 4-month timing. The typical half life of, say, IgG antibodies is about 21 days. And you need 4 cycles of half life of a half life of a half life of a half life to get down below less than 10% of the original level of antibodies. This is accomplished in about 3 months of time. But we know that food eliminations can be challenging for patients, and often they need to try to eliminate for 4 months in order to actually struggle a little bit in the beginning and then eventually get 3 clean months of elimination. This helps to ensure that the antibody level is quite a bit lower. Then, when you do a structured reintroduction of a food, you're much more likely, if there is a residual immune reactivity, to trigger a palpable enough response that it is immediately noticeable as a symptom by your patients. And a structured reintroduction, you want to do one food at a time. If you reintroduce all 3 or 4 foods someone eliminated, and they quickly realize symptoms of fatigue the first day and maybe a headache the first night and perhaps joint pain the following morning, we have no way of knowing which of those food reactivities indeed went away during the elimination, and then which one or more of them are persistent. So you want to reintroduce foods one at a time, and we recommend that you introduce them in significant enough quantity to, again, provoke a noticeable response. We typically recommend 2 normal-sized servings a day for 3 days in a row for the food that's being eliminated. And remembering that immune hypersensitivity responses are often delayed, in some cases as much as 72 hours. So reintroducing the food for 3 days, then stopping, and then allowing the full elimination to be restored for the follow-on 4 days, paying attention, making note of reoccurring or new symptoms, and then the following week, reintroducing a second food. You can learn to master this process so that food sensitivity testing is properly assessed and implemented with regard to elimination and reintroduction protocol. But keep in mind that symptoms can go way beyond the gut, but they might be major mediators of your patient's acid reflux, bloating, GI dysmotility, burping, pain, stool irregularities, and the like. Now, myth number 5, food sensitivities are either random, you just pick them up, or they are genetically hardwired. And certainly, as I mentioned, in some few limited cases, there may be a genetic predisposition for that and a lifelong hypersensitivity. But most often, food sensitivities are acquired, and they are indeed reversible if we do 2 things. Number 1, we eliminate the food long enough to allow the immune system to calm down and to stop being reactive to that food, because from its perspective, the threat has been eliminated. But alongside the elimination, again, you have to address why the immune system was hyperreactive. And this can be, as I said, often loss of barrier function in the gut that might be mediated, for example, by medications, chemotherapy, steroids, oral contraceptives, non-steroidal anti-inflammatory drugs. There are a number of different medications that overtly promote intestinal permeability and naturally attract the terrain that promotes loss of tolerance to foods. It's also true that food additives artificial sweeteners, colors, pesticides, herbicides, preservatives. There are many different chemicals in our foods that can activate excessive activity in sentinel cells, dendritic cells. That might also be promoting mucosal mast cell activation. All of these toward escalating immune reactivity. Dysbiosis in the gut can be, again, promoting hypervigilance and leading to a loss of optimal T regulatory cell function. Poor digestion, I've mentioned, toxic load. There are a number of different mechanisms that can create the terrain for food sensitivity. And so, what this means is that we have to eliminate the food, but we also have to identify and resolve the root causes for why this person became sensitive to foods via these antibody pathways. And you can learn to master these as a practitioner, and it can be a very effective clinical tool for building, forging clinical partnership and engaging your patient in targeted activity to reduce their inflammation and see that their behaviors have a direct and potentially very significant impact on their symptoms and suffering. So, not true at all that we can't resolve the vast majority of food sensitivities. We can, if indeed we are persistent and appropriately target both elimination and terrain adjustment. Now, myth number 6. Once you find out that you have a food sensitivity, you can just rotate the foods or reduce them a little bit for a few weeks, and the process, the imbalance will heal itself. We would all perhaps like for that to be true. It sounds simple and easy. But the reality is that healing the hypersensitivity takes more than just a reduction. It takes more than just 2 or 3 weeks of elimination. And as I've highlighted already, we need to approach reintroduction in a focused, structured way. If an individual does indeed have loss of barrier function in the gut, then we definitely have to consider that a hyperreactive immune system can also develop cross reactivity. This means that a person may react to a food that molecularly looks a little too much like another food that it has a strong antibody response to. And this is especially going to be the case if an individual has maldigestion. Maybe they have low stomach acid, hypochlorhydria, because they're using proton pump inhibitor medications and lowering their stomach acid on purpose. Or perhaps they have pancreatic insufficiency because they have type 2 diabetes and the pancreas is working suboptimally for both endocrine and exocrine functions. When we don't properly digest our foods are naturally more immunogenic. Foods are naturally more likely to provoke an immune response because they more frequently fit the definition of stranger danger that causes the immune system to respond. This is where, for example, ongoing food sensitivities and reactivity to certain molecular profiles can also potentially lead to the development of autoimmune dynamics. So food sensitivities are not to be tolerated just because the symptoms aren't that debilitating. We want to identify and reverse the immune hypersensitivity so that it doesn't spill over eventually into not only foods, but also hyperreactivity to tissues, to self-tissues that could eventually promote autoimmune disease. I mentioned earlier that there is no one single test that covers everything that we might consider in terms of foods promoting inflammation. And I've mentioned that there are some pathways that aren't assessed in any testing. Potentially in terms of a reaction to a overload of a natural food component like lectins or phytates or oxalates, or other phytonutrients that are common in various types of foods, whether it's nuts and seeds or high sulfur containing vegetables, for example. People can poorly tolerate or feel poorly after consuming foods for a variety of reasons. But make sure that you're choosing tests that really support what you are trying to assess. I mentioned KBMO's FIT test is looking at total IgG with complement, which helps to maximize the reliability of positive findings. On the other hand, there are other companies, for example, like Cyrex, which offer both IgG and IgA panels that take the extra critical step of looking at the difference between tolerance of raw foods versus cooked foods and ensuring that we're doing testing based on the form of the food in which it is most often consumed or even both forms. There are several different companies that offer pure IgA panels, such as US Biotech, which again can help us to better characterize this loss of food tolerance in the mucosa, especially key when you know there are problems with gut imbalances. Vibrant Wellness offers a variety of combination panels. As I mentioned earlier, you can mix and match and combine with their testing, perhaps IgG with complement and also IgE, looking for food allergies, and then IgA as well. These are just some examples of many different testing companies out there. Genova Diagnostics also has a number of excellent food panels, but you want to choose the type of panel based on who is this person. They also have highly variable costs that we must keep in mind with regard to accessibility for a unique patient. The myth number 8 that I want to speak about for a moment is that you can do a food antibody test at any time. It doesn't really matter, and you will uncover reliable food sensitivity data. And the truth is actually that timing matters, because when we do food sensitivity testing in an environment in which a patient is experiencing atypical circumstances, then we will likely get abnormal test responses. An individual might be temporarily, for example, using a course of steroids because of a bad poison ivy outbreak. Or they may have had recent antibiotic use, or maybe they had a bout of food poisoning, or they've gone through a very stressful period of time. Any or all of these can exaggerate and skew immune responses to our environment. So we often recommend waiting where possible for a good 6-week period on the other side of any of these circumstances that might overtly either overload and therefore promote dysregulation of the immune system, or suppress and therefore leave immune reactivity under responsive, abnormally calm. We want to make sure we are doing the testing at as normal a time as possible for a unique individual so that we can we can rely on the results as being well representative of their normal state. Now, myth number 9 is about interpretation. A lot of people believe the test results are the end of the conversation. You just look at the colorful results panel, and if there's a reaction to a food, it's a problem and it should be eliminated. But as I mentioned earlier, there are reasons behind the food sensitivities, and our case-specific interpretation is key. For example, if you do need to use a food antibody panel in the context of, say, a patient who has chronic autoimmune disease, maybe more than one, and they are using a biologics medication that we know is overtly immunosuppressive, we want to interpret food sensitivity data knowing that the immune system in general is a bit turned down. And so we need to honor those borderline responses or the mild reactions as potentially being more nominally quite stronger. And it is simply the effects of the drug that are suppressing the ability to have a more normal, measurable antibody response. We must ask, who is this person? Similarly, when we look at test results and we see that they didn't just respond to one or two grains, they were essentially having some type of response to all grains, then we want to be thinking about what might be some of the cross-reactive patterns at play. Again, people might respond to all nightshade vegetables or all nuts. Perhaps there's fat maldigestion, and that is promoting immune hyperreactivity to foods that contain a lot of fat because they're not being well degraded and therefore attracting more reactivity from our immune system. Or perhaps in the case of grains, an individual, especially whole grains, an individual may be struggling with lectin overload in the gut. And this may be why they have GI symptoms, but it may also speak to why they are reacting to an entire family or class of foods. So we don't just want to look at the results and say yay or nay in terms of whether a food is recommended. We want to consider what is at play in a unique individual. And so reframe test results as a starting point rather than a singular diagnostic conclusion. And again, we want to partner with each unique patient in a partnership to support them with education, inspiration, and specific tools to achieve effective eliminations and anticipate at the right time a structured reintroduction so all of their effort to change their diet is not a waste. Now, myth number 10, I want to say a special word about gluten. Just because an individual does not show elevated antibody levels to gluten does not mean that gluten is not a, a strong promoter of inflammation and functional imbalance. And there are many different pioneers I want to give credit to in this discussion. Certainly, Dr. Alessio Fasano has helped us through his research to understand just how often in strong zonulin secretors, there can be a particular sensitivity to gluten that promotes greater zonulin that helps to promote loss of barrier function and enhanced intestinal permeability. This can happen without there being elevated food antibody levels. Loss of barrier function is a foundational driver of immune hypervigilance, as I was mentioning earlier. And so we must teach people in advance of seeing their test results that if leaky gut is a known or highly suspected issue, then gluten elimination is recommended, at least for a time, regardless of what the test results have to say. This is especially key if you have gut barrier functioning test results and you know that an individual has high antibodies to things like zonulin or lipopolysaccharide or candida or occludin as evidence of that loss of barrier function. And certainly, as I was mentioning earlier, expectation setting, partnership with your patient is really essential because we tend to be quite attached to our diets. No one is excited about changing up their diet and eating foods that are unfamiliar and perhaps giving things up for a full 100% elimination that they like, that tastes good, that feel good in their body, that's part of their habit, their tradition, their rituals. So it's important for all of us as practitioners to remember that food eliminations are challenging. Now, for individuals where they seem to light up for all the foods and their immune system in general seems to be reactive to everything, keep in mind that elimination of all the foods is seldom necessary. Usually, in that scenario, if we would simply eliminate all of the severe reactivity foods, or if you have IgG with complement, for example, eliminating fully all of the severe and the moderate food sensitivities, then that can lead to a reduction in inflammation that, along with other terrain modulating activities, can help to calm the immune system enough that we don't really need to worry about the mild or lower level moderate responses. Again, the vast majority of food sensitivities are acquired, and elimination is necessary in order to calm the immune system down. But it's just as important that we go upstream and find the root causes of the hypersensitivity in a unique person so that we can change up the terrain and make it logical, reasonable that future hypersensitivities would not occur, and that upon reintroduction after eliminations, a food sensitivity can indeed go away. And if you learn to very capably use functional medicine clinical tools to achieve this, you find that 80–90% of the time, a good solid 4-month elimination is plenty for helping someone to fully remove and eliminate a food sensitivity, as well as the symptoms and suffering that it was causing. I hope these 10 myths and truths are helpful to you in understanding some of the clinical nuances of food sensitivities. For sure, I encourage you to consider food always in your clinical plans, but not just how food can be a positive or even how food could be a nutritionally or toxic negative, but how might foods be a trigger for inflammation and immune hypervigilance that's promoting other manifestations of chronic disease. If you've enjoyed what you experienced today, please hit subscribe, and I look forward to joining you next month. Have a great day.